an infection with SARS-CoV-2, and in a month, this is acute COVID. Then after 4 weeks, we call it a post-acute COVID. But now we've seen that there are ongoing manifestations which go between 4 weeks to 12 weeks, and those will last even more weeks and longer. This is the chronic COVID. And you have seen that post-viral convalescence of COVID-19 can last several months to a year or longer. And this will define today what we call the long COVID. But confirmation will need the previous infection with SARS-CoV-2 or evidence of positivity PCR or nucleoparasite antigen. Slide, please. Slide, please.
Okay, so before we proceed, we'll just pause for a poll question. I'll read the poll question. So the poll question 1 reads, which of the following is reported as the most common long COVID symptom? There is A, chest pain, B, fatigue, C, heart palpitations, and D, shortness of breath. So I'll read that again. Which of the following is reported as the most common long COVID symptom? Is it A, chest pain, B, fatigue, C, heart palpitations, or D, shortness of breath? So IT, could you launch the poll? We're just giving a few minutes to IT to launch the poll, and then we'll allow the network to answer the question, and then we'll proceed to the following slides. All right, so IT having a bit of technical challenges with uploading that poll, so we'll just go ahead. So actually the most common long COVID symptom that has been reported from the various studies that have been done is actually fatigue. So we'll move on to the next slide. Probably by the time we reach to the second poll, IT would have sorted out the IT issues. Back to you, over to you, Dr. Chimanuka.
Thank you, Dr. Matubula. Then, since the beginning of COVID-19 pandemic in 2019, the world has recorded about 423 million people with SARS-CoV-2 and 6.3 million of deaths, which represent around 1.2 to 1.5% of death. Among this, they've noticed that 10 to 35% of those who survive from the COVID, then they'll proceed to the long COVID. Then 10 to 35% will proceed to long COVID. Then long COVID recovery is similar to other illnesses. Then that makes the difficulties even sometimes to differentiate if it's a long COVID or another illness. But there is an explained persistent trend which is unique to SARS-CoV-2. And this due to some manifestation, and when they run some tests with the history of past infection to COVID-19 or positivity of the test. There are differences in incidence of severity which can pass. Now, they've seen that various long-term complications which result from long COVID account of cardiopulmonary, where we have persistent physical and mental symptoms. But the most common are fatigue, which account between 15 to 87%, dyspnea, 10 to 71%, chest pain or tightness, 12 to 44%, and cough, 17 to 34%. There are also some cases of cognitive impairment. The variability in the disease progression and recovery and can lead to the prognosis, which depend on the pre-existing risk factor and the severity of infection. Then it has been noticed in some studies that those who have pre-existing risk factor, like old age between 40 to 60, like pre-existing comorbidities, and women more than men, those who have a greater BMI, obese, and those who have a medical complication, or those who are the severe infection, they do have those predisposition to long COVID. Slide, please. Dr. Matibula?
All right, thank you for that, Dr. Chimanuka. So again, we pause for a short poll. Unfortunately, IT is unable to launch the poll. So I'll just ask the network to post the answer in the chat. I'll be able to see. So once 1 or 2 or 3 answer the poll, then we'll proceed. I'll give a comment. So the question reads, which of the following conditions are consistent with long COVID presentation affecting the cardiovascular system? Is it A, raised troponins, B, palpitations, C, chest pain, D, myocardial inflammation, or E, all of the above? So the subsequent slides speak to this question. So dear network, you can respond by just typing your choice of answer in the chat. Right, so I have a few answers there, most of them going for E. Right, so actually E is the correct answer. All the options from A to D are actually presentations that can affect the cardiovascular system. Thank you for those who responded. We'll move on to the next slide. Dr. Chimanuka, over to you.
Thank you, Dr. Matibula. Then this is a picture which gave us the different manifestation of sequela in the long COVID. Then we can see on this slide the famous ACE2, which is the common cell which is implicated in the COVID-19 and the different system. Then started by the heart, you'll have chest pain, you have myocardial inflammation with the famous myocarditis, which is predominant. We'll have persistence of troponin abnormalities that they can find on test. And you have the palpitation, like in that case that Dr. Matibula presented. Then you have to the lung, the dyspnea, the chest pain, and the cough. And you can say that the cardiac and the respiratory do have a common manifestation, like we'll have chest pain, and you'll have also dyspnea, and you can also have the cough. Then on the other side, you have down, you have the pancreas, where you can have a pancreatic injury and pancreatitis. Few cases, I don't know, maybe Dr. Matibula will share if you have some cases about this. Then you have the kidney, where we have a renal impairment and acute kidney injury. And we need to say that even those patients who have a kidney disease are prone to have COVID-19 infection. And some of them, they do have the post-COVID, and we need to determine if they don't have also long COVID. Then gastrointestinal, then you have the rest. Yes, the previous one, please, just 1 minute, please. Yes, you have gastrointestinal, then you have on the blood vessel, the liver, the spleen, and the brain. Next, please. Then when you see the epidemiology of the cardiovascular manifestation of long COVID, then the prevalence varies according to the population which is studied. And it has been found that acute abnormalities resolve over time, but some finding may remain. And you'll find like left or right ventricle remodeling when you do echocardiography. You'll find the systolic or diastolic dysfunction with pulmonary hypertension in those patients who suffered COVID-19 without any other explanation, or a reduced left ventricle or right ventricle function. But we do also have some cardiac manifestation which occur in some patients with already pre-existent cardiac condition. And it becomes difficult sometimes to differentiate if these are the pre-existent cardiac condition which persist or become complicated, or these are new really due to the COVID-19. Slide, please. Then this is the slide which shows some cardiac complication and their prevalence in patients with long COVID. Okay, then you can see that patients who were found to have chronic myocarditis, then the patients studied were between 48 to 543, and they found 0.4 to almost 30%, which is quite significant. And this is why myocarditis is one of the main complications which in the treatment, as Dr. Matibula said, that we need to emphasize on. Then we have a chronic pericarditis, where we have 1.9 to 27%. We have myocardial edema, 15%. We have myofibrosis or SCAR, 4%. We have systolic or diastolic left ventricle dysfunction. You have up to 55%. You have right ventricle systolic dysfunction between 7 to 22%. Left ventricle thrombus, 2%. Coronary artery disease, 8%. Acute myocardial infarction, 1.5 to 8%. And persistent systemic endothelial dysfunction, 2.5 to 6%. And when we see this table, then Dr. Matibula will go through the next question.
All right, great. Thank you. So network, you've seen some of the frequencies of these cardiovascular presentations in long COVID. We will now move on to question number 3. Again, once you are able to answer, you just post your answer in the chat. So the question reads, what pathophysiologic features explain cardiac manifestations of long COVID? Is it A, residual cytokines from the acute phase? B, dysregulation of the renin-angiotensin-aldosterone system? C, is it breakdown of ANP, BNP by neprilysin? Is it D, A and B, correct? Or is it E, only C is correct? So encourage the network to attempt. All right, so there are some answers coming in. So far we have D. Right, it seems people have done very good homework on this topic. So actually D is the correct answer. Both A and B are correct. We'll see from the following slides that some of the pathophysiology, of course, there are a number of pathophysiologic explanations or theories. Some of them may even involve non-cardiac systems, but residual cytokines have been thought to be contributing factor, and also dysregulation of the RAS. So A and B are both correct. Over to you.
Slide, please. Thank you, Dr. Matibula. As the question stated, then most of the pathophysiologic are around the residual cytokine and the dysregulation of the renin-angiotensin-aldosterone system. Then if you see these features, you have the COVID-19 infection, you'll have the symptom of resolve, or the symptom don't resolve, you go to post-acute phase of the infection. And when the symptom persists, Then this is due to the residual cytokine from the acute phase. We'll have autonomic dysfunction and dysregulation of the renin-angiotensin-aldosterone. We'll have the mediated damage and oxidative stress, and this will lead to the cardiovascular complication, arrhythmia, inflammation of the heart, then thromboembolism. And this will give us the cardiovascular burden. Long COVID is a multi-system disease which develops, and regardless of the initial disease severity, and comprise a wide range of symptoms, as we saw in the other features. The underlying mechanism is still unclear, but there are organ damage from the acute infection phase likely account for the symptom with the residual cytokine, with the dysregulation of the renin-angiotensin-aldosterone system for the heart. Then existing studies involve long COVID patients are highly heterogeneous. They involve patients with various COVID-19 severity and with different time frame for analysis. Slide, please. Then the persistent, the preview one. The persistent cardiac abnormalities secondary to myocardial injury are due to limited coronary perfusion or severe hypoxia. Then you have a cardiac symptom will rise from the virus-induced microvascular disorders or inflammation. And you have the systemic inflammation, the invasion of cardiomyocytes by SARS-CoV-2 through the SCA2 receptors, and this will lead to the heart dysfunction. Slide, please. By the prolonged inflammation, we'll have some structural remodeling in the heart. This will lead to the fibrosis or to the changes of the chamber's size, and this will determine the heart failure or the arrhythmias. We'll have microvascular endothelial dysfunction within the heart, and this in the vessels will provoke some microthrombi, impairing appropriate vascularization that can explain the hypoxia and the hypoperfusion. The viral invasion within the endothelial cell and the cardiomyocyte will determine inflammation and a general dysfunction. But we'll have also some autoimmune disorders. For example, the antiphospholipid antibodies, and this could be possibly contributing to vascular inflammation and thrombotic complication. Slide, please. Then the persistent inflammatory process is suggestive of the vasculitis within the large vessel. For the nervous autonomic system disorders, autoimmune-mediated dysfunction and the antibodies against the catecholamine receptors or the endothelin will also be found. And on the molecular level, we'll find the prolonged cellular dysregulation with self-auto-damaging effector responses by autoreactive B and the T cells. Then this is a feature where we have cardiovascular system and the other side pulmonary system, because we say that they will share some of the common manifestation. Then we'll have one side the endothelial cell dysfunction or the cardiomyocyte injury due to microthrombosis, thromboinflammation, microangiopathy, then conduction abnormality and fibrosis. On the other side, we have the autonomous nervous system injury, and on the other side, down we have the lung fibrotic remodeling and the pulmonary vasculature. These are coming from the inflammation from the SARS-CoV-2, that infection which leads to some residual cytokine or some dysregulation both in the heart and in the lung. And this will determine that we can have an acute coronary syndrome, myocardial infarction. Most of the time we'll have heart failure unexplained and without risk factor, expect the COVID infection, COVID-19 infection. We'll have some arrhythmia and the stroke. And most of the patients will present with fatigue, as they said. Then they'll have breathlessness, post-exertional, will have chest pain, palpitation, and exercise intolerance. But some of them, they'll have cough and dyspnea with oxygen diffusion, which is disturbed. Slide, please. Then here, this is another slide which shows that on the cellular level, their cells will be implicated. Mast cells will release some mediator. Then we have B cells, and T cells from the autoimmune system. We'll have the circulating endothelial cell, the neutrophils, and the monocyte. And on the vascular, we'll have an endothelial dysfunction, which lead the paroi of the vessel more sensitive to other injuries, and this will explain the formation of vasculitis, thrombosis, and coagulopathies. On the molecular level, you have the mitochondria will be disturbed in its work, then it will not produce enough of the energy for the ATP, and the cells will suffer, and will have the loss and some oxidative substance which will be accumulated in the cells. Then we'll have also the persistence of some viral particle will invade the other organ, and essentially here, the heart as we're talking. Slide, please. But there are many mechanisms which will happen in the long COVID, and those will contribute to the cardiac sequel. Then we talk about the T cell and the B cells. This, we have the interferon gamma. This will secrete some cells and activate the CD8 and the T cell exhaustion. Then we'll have also this regulation of the specific memory of SARS-CoV-2 through the beta cells. On the hematopoietic level, we'll have some progenitors like epigenetic, which will be reprogramming. Then there will be some cells which will be activated. And on the master cell activation, we'll have circulation endothelial cells. Neutrophil will release autoantigen. We'll have the monocytes, and we'll have even some protracted immunosuppression by latent virus reactivation. Slide, please. The mitochondrial dysfunction, the senescence and the telomere shortening of the blood cell, plus the oxidative stress will play also another role in the molecular mechanism. We can have also some genetic mechanisms with the associated X chromosome or ACE2 receptor disturbed. Then we'll have a vascular and endothelial mechanism where we'll have deterioration of capillary integrity. We'll have the whole endothelium system which will be affected. We'll have the capillary flow disturbances. We'll have vasculitis. We'll have thrombosis, and we'll have coagulopathies. But they do find in some studies that in those patients who suffered long COVID, they have also persistence of viral particles in the myocardial tissue, hidden in the reservoir of other organs as well. Slide, please. Some other mechanism on the cellular level will have dysregulation of the SARS-CoV-2 memory beta cells. Then we'll have the interferon and the other cells which came with the cytokine from the previous infection. And you have a lack of beta and T cell expressing CD127. Then this, when they did the study, they found that this patient carry these cytokine, these cells in the blood, even up to 6, 8, and 9 months. And this shows like, due to those residual cytokine, we still have some manifestation of the COVID, and we say this is a long COVID. Slide, please. Then we'll have also some elevated activated cells, which normally after inflammation, they rapidly disappear. But in long case COVID, they found that these cells can be there even up to 8 months in the blood. When they test, they found those cells are still elevated. CD14, CD38, CD16. Then this persistence of these cells shows that this disease is not yet finished. And this is why we call it the long COVID. We'll have also persistence of activation of some cells. Doctor, then this will go to the fourth poll question. Dr. Matibula.
All right. Thank you for that detailed explanation on the pathophysiologic features, Dr. Chimanuka. So we pause for another poll question. Network, you can simply post true or false in the chat box as our IT is unable to upload the poll. So the question reads, cardiovascular system, cardiovascular symptoms of long COVID, consequence of multiple cardiac and extracardiac pathological sequelae. So you indicate whether this statement is true or false. Is it true that cardiovascular symptoms of long COVID are a consequence of multiple cardiac and extracardiac pathological sequelae? I think part of this has actually been addressed in the previous slides, so I'm sure network is able to post. Yes, so I can see a number of truths. Yeah, so this statement is actually correct. We've seen from the previous presentations the number of pathological processes that are taking place to contribute to these cardiac sequelae. Thank you for those that have responded. We proceed to the next slide. Dr. Chimanuka, over to you.
Thank you, Dr. Matibula. Now, after to go through the epidemiology of this manifestation and try to elucidate some of the mechanism in the pathophysiology, we need to think about how to diagnose long COVID cardiovascular manifestation. But what will be, or what will be the aim for this diagnosis? When we try to look for this cardiovascular manifestation, we try to verify and exclude objectively the organ disorders. Is it only cardiac manifestation due to COVID-19 or due to other cause? We try to check the unexpected progression of the pre-existent diseases. As we said, there is the COPD, coronary artery disease, CKD, diabetes, hypertension. These patients do have, with time, some complication to the heart. Now, those manifestations that we are having, are they not due to the pre-existent diseases? We try to look also for the newly developed autoimmune or post-inflammatory chronic myocarditis or lung fibrosis. Some even went and say that any cases with a myocarditis of a lung fibrosis without any found case, you need to try to rule out that it's due to COVID-19. Cardiovascular symptoms of long COVID are consequence of multiple cardiac and extracardiac pathological sequelae. Some are due directly to the previous infection. Some are due to the pre-existent diseases with the COVID-19 infection, which make this person to be more susceptible to get more complication. And generally, the patient with severe symptoms or elevated cardiac enzyme have a high mortality. Why? Those who don't have symptoms can remain and survive this infection. Slide, please. Then here, these are some common cardiac manifestations of long COVID. Okay, we have people who come complaining of fatigue is true. We'll have people who come and complaining of shortness of breath. We'll have people who have only ECG abnormalities without any explanation. We have people who have chest pain. Those will come in heart failure with or without myocarditis. And some, they'll have some arterial vessel inflamed with thrombosis phenomena in others. Slide, please. These are some of the common cardiac manifestations which are reported. Then these manifestations are based on the patient's symptom and their prevalence in a long COVID patient. Then we have this long COVID where we have more than many weeks. And you will see in those who have lax just post-COVID. Then, for example, the chest pain, they found that those who have post-COVID, they'll have a chest pain in 5 to 30%. But those who have long COVID, they'll have chest pain between 12 to almost again 30%. Those who have palpitations, they found that in post-COVID, palpitation was up to 20%. When in a long COVID, palpitation plus other cardiac arrhythmia, essentially atrial fibrillation, was going up to 32%. Then if people were complaining of difficulties in breathing in post-COVID percent up to 70%, then in long COVID, there are people who complain up to 90%. Then we can see that from the acute, it's like there is an exponential increasing of this cardiac manifestation from post-COVID to the long COVID. As you are going toward post-COVID and long COVID, if you add an infection to COVID, you are at risk to have this manifestation. Slide, please. Dr. Matibula?
Thank you, Dr. Shimanuka. So we pause for another question. So you just post the answer in the chat again. The question reads, which of the following conditions can occur after an episode of COVID-19? Is it A, hypertension, B, stroke, C, diabetes mellitus, D, venous thromboembolism, or is it E, all of the above? Again, which of the following conditions can occur after an episode of COVID-19? Is it hypertension, stroke, diabetes, venous thromboembolism, or is it all of the above? Great. So I can see some answers, and everyone is actually going for the correct answer, which is E. So it's true that all the conditions listed, hypertension, stroke, diabetes mellitus, and venous thromboembolism, can actually occur after an episode of COVID-19. In some cases, it can be a new onset hypertension, or new onset diabetes, or even just worsening of a pre-existing hypertension or worsening of a pre-existing diabetes. I think we've seen from some of the pathophysiologic features that COVID-19 can affect the pancreas, and that can lead to either new onset diabetes mellitus, or even worsening of pre-existing diabetes. Thank you for those that have responded. We'll hand back to Dr. Shimanuka to continue with the next slides, which actually look at some of the conditions that can occur after suffering COVID-19. Over to you, Dr. Shimanuka.
Thank you, Dr. Matibula. Then these are new onset cardiovascular disease, which are associated with COVID-19. Then this newly complication and their prevalence in patients with long COVID is increasing. Then we found that hypertension is increasing up to 1.3%, diabetes mellitus up to 2.4%, stroke up to 6.7%, venous thromboembolism up to 12.5%, and among hospitalized people, then 29.4%. Slide, please. Dr. Matibula.
So we pause for another poll question. You indicate whether this is true or false. N-terminal pro-BNP can remain elevated for 6 months after an episode of COVID-19. So indicate whether this biomarker can remain elevated for 6 months even after a single episode of COVID-19. So again, the network, you can simply post the answer in the chat. I can see so far there's a true there, another true, another true. Yes, and this is true that there are actually a number of biomarkers that can remain elevated for quite a number of months, and we'll see from the subsequent slides some of these biomarkers. So this statement is actually correct.
Then when we try to do some tests, as we said in the pathophysiology, we found that there are circulating inflammatory markers which remain in the blood more longer than before. If someone has myocardial infarction, in a week up to 2 weeks, then those cardiac markers will go down according to the progress of the disease. But they found that in the patients with long COVID, troponin TOI remain up to 71 days, which is almost like 3 months, 2 months to 3 months, sorry. Then we have also the anti-BNP, which we use for heart failure, which goes and remain up to 9 months. But normally in those patients who have heart failure, it gets elevated as we are treating the patient, the NP will go down. But in those patients who have long COVID, we'll find that these markers remain longer. And if there are no other cardiovascular explanation, this is long COVID. Inflammatory biomarker, you have a CRP, which can remain between 1 month to 3 months. Some cytokine would remain between 2 weeks to 3 months, others up to 8 months. Of course, in our country, we don't have all these facilities for the interleukin, but we have like the CRP, which is there, and some lab that can test 1 or 2 of these cytokine. If we have this persistent of the CRP, then we think about long COVID. We have also coagulation biomarker, like a patient who have a D-dimer, which remain positive for 2 to 3 months. Those who have a factor 8 thrombomodulin up to 9%, and this remain longer. In conclusion, long COVID sequela is multisystemic with some cardiovascular manifestation. Fatigue is the most common long COVID symptom, and the cardiovascular system is not spared. Some cardiac biomarkers may persist for some times, from 1 month to 3 months, even going around 8 months to 9 months. When you consider the pathophysiology, remember residual cytokine and the dysregulation of the renin-angiotensin-aldosterone, plus endothelial dysfunction and thrombosis. The aim of the diagnosis is to verify and exclude objectively organ disorders, check an expected progression of the pre-existing diseases, and look for newly developed autoimmune or post-inflammatory chronic condition. Thank you, Dr. Matibula.
Right. Thank you so much, Dr. Chimanuka, for that elaborate presentation. So just go over it again. Here, network today, we were looking at cardiovascular manifestations of long COVID with a focus really on the pathophysiology, the epidemiology. This is just part 1. So in the next session, we are going to look at part 2, where we'll zero in on a single case of myocarditis and look at some of the cardiac investigations that we can do to try and evaluate patients with cardiac manifestations of long COVID. But we've seen from this presentation that there are various pathophysiologic mechanisms that can explain some of these cardiovascular presentations. For example, the issue of pre-existing cytokines from the episode of COVID-19. There is dysregulation of the renin-angiotensin-aldosterone system. And then we must acknowledge that there is also this important interplay between the cardiovascular system and other systems at play, and also other mechanisms in the background. For example, Dr. Chimanuka explained some of the cellular mechanisms that are at play that contribute to these cardiac manifestations, some of the molecular mechanisms at play that contribute to these cardiovascular manifestations. I must say it was very elaborate, and this will continue in the next session, where we'll zero in on the investigations and get one example to try and see how it's managed. So in the previous case that I presented earlier, the issue of the patient presenting with palpitations was actually as a result of having had COVID. So this is a long COVID patient who has been managed with just beta blockers, and they've reported improvement of the symptoms. So at this point, I open up to the network and some of the experts that we have logged in. Any comments on this topic, and any questions that the network might have regarding this topic, bearing in mind that it's a series. This is only part 1. Have the second part the following week, which will look at investigations and some aspects of management. So over to you, network. Are there any questions? If you have a question, you can simply raise your hand, or if you have a comment, contribution, you can simply raise your hand. I don't know if some of the cardiology team from the Heart Hospital are logged in. Dr. Sharek Essa, Dr. Edward Shabani, any contributions you have on this topic, or experiences that you've had with managing some of these patients who come with cardiovascular manifestations after having had COVID-19. Over to you, network. Going once, going twice. Okay, I don't see any hand raised. I don't see any questions in the chat. So it simply means Dr. Chimanuka did a very good job at explaining some of these pathophysiologic mechanisms, and people don't have questions or any contributions to add. So in terms of some of the experiences we've had, of course, there is the example of a case that I gave with palpitations. There is another client that we saw in the acute phase who actually presented with acute heart failure that was thought to be as a result of the myocarditis that they had. We've seen a number of cases of new onset diabetes and worsening of previous existing diabetes, or even patients who've moved from pre-diabetes going into overt diabetes. We've actually had a number of cases presenting like that, though I haven't yet seen a case of acute pancreatitis due to COVID-19. Probably some physicians on the call have experienced that. You can share your experience. Right, so colleagues, it's 12 hours on the dot. Thank you for the network. I must say the people who logged in were quite many. And thank you for the responsive network that we've had. They were responding to all the poll questions by posting in the chat. Thank you so much. Thank you once more, Dr. Chimanuka, for this elaborate presentation. We look forward to the part 2. And thank you to the rest of the network that joined. If there are no more questions from me, Dr. Matibula, and the rest of the team here, I'm joined by Kote and Chatonda as our IT. On their behalf and behalf of everyone, we say thank you so much and hope to see you next time for the part 2 of this series. From me, Dr. Matibula, infectious disease specialist UTH. It's bye-bye for now and have a good afternoon. Thank you.